It's a pleasure to be here. My name is Andres Nieto. I'm Senior Director of Community and Population Health at New York Presbyterian Hospital, and it's a pleasure to be here with my colleagues from throughout the city. They've asked me to be a facilitator, and as Lisa, I think, did a great job in giving a synopsis of what we're going to be discussing. But I have some things that I wanted to share with you first before we get started. In order to make the roadmap more, both relevant and actionable, we hope to clarify, define the roles of each sector in implementing each of the roadmap's key action steps. So in the workshops, we will review each key action step and ask one or two questions aimed at identifying what would be required of your sector for our shared plan to be successful. To make this work, we are proposing some guidelines to make sure that we accomplish what we need to do in a time of audit. So one, speak as a representative of your sector and avoid commenting on the role of other sectors. This will help us get a clear role definition we are aiming for. Two, one group member, one response. For this session, we want to limit the crosstalk. If we have time after getting through the questions, we will open for general discussion, and there will be a larger conversation when we reconvene with the larger group. So please feel free to comment. Please hold your comments until then. Three, focus on the questions and action steps at hand. We know many sectors are interrelated, but we are likely to stay as narrowly focused as possible for this discussion. We will be discussing as a group, and I was told for 45 minutes. Is that right, Zach? Is that still the amount of time?
Yes.
So for 45 minutes, and we'll begin to summarize and recap the key takeaways 5 to 10 minutes before the session ends. We will be asked to provide a brief report back when we return to a larger group. And Zach, I was told that you will report out the findings of this group at the larger session. Is that true, or is that not true?
No, it's you.
Okay.
But I'm assisting you.
Okay.
I'll
Right,
be I'll be recording and documenting the key takeaways, which we'll summarize, and then if you don't mind.
No, not at all.
Okay.
I'm fine with that. So the key actions are: one, secure diversified, flexible, and sustainable funding for citywide community resources. And based on our previous sessions, it was clear that limited access of community resources based on affiliation with healthcare plans and providers would be independent of health equity in New York City, where there remains a large undocumented population and maybe people disconnected from care. Based on these conditions, the roadmap recommends diverse funding models and infrastructure that allows accessibility for all New Yorkers. So the first question is, what do you see as your sector's role in financing community resource network? So I think the best way to go about it is if we raise our hand on the chat, on the Zoom, so that we won't be talking over each other.
Could you repeat that question one more time?
Sure. What do you see as your sector's role in financing a community resource network?
I don't know how to raise my hand, so I'll just do it
Okay.
like this.
Carla.
Yeah, no, that's fine.
I'll start. I'll break the ice.
Thank you.
I mean, I think one important thing to do within the healthcare sector is probably to improve data collection internally about the social needs of patients, the needs in communities, make improvements to data that supports health equity related activities. I think that collecting that data helps to make sort of strategically driven decisions about where or how to potentially flow funds what services to pay for. And so I think that would be a key step. And I think some of that has started already. And, you know, I think there's also a role to help organizations that may be healthcare organizations that may be a little further behind in that and maybe having a hard time, and think through, you know, how can some of us provide technical assistance and maybe even resources to improve that. And that would support, I think, healthcare organization investments as well as inform the state Medicaid program on potential investments.
So, Carla, can you just let us know what organization you're representing?
Oh, sure. Sorry. I'm with Greater New York Hospital Association.
Great. Thank you, Carla. Anyone else have any comments? Yes, Erica.
I would totally agree with that, and then add infusing screening and how to screen for social needs as part of that data collection, the demographics and so forth too. And I think part of the question was about the financial model. I think we need to think about that in terms of how to engage the network and the CBOs and the VBP arrangements so that it's more visible across those organizations that are also participating in the care for that patient.
Yeah. Second question is what sources? I'm sorry, Zach, did you want to say something?
No, go ahead. Sorry.
What sources of funding would support both startup and ongoing costs of a citywide community resource network that your sector is uniquely qualified to tap into?
So here we're really talking about what are resources that healthcare systems and hospitals have access to in terms of funding that are unique to your sector, to doing this work, to investing sort of in connections between healthcare and community resources.
So, you know, I don't know if as a facilitator, I'd like to comment a little bit, maybe get the conversation started, because, you know, one of I think things that we can do is use our community benefit dollars to fund some of these types of resources as a non-for-profit organization. And then in our organization, we have begun to do, and Dr. Meyer can speak more to it because she's really leading a lot of the efforts of, screening for social determinants of health, identifying what are some of the issues that are affecting our patients specifically in the communities that we're serving, and then creating programs to address some of those needs, and then also using community health workers as a vehicle to help patients navigate the resources that are in the community for them to tap into. Anyone? This is a quiet group, Zach. Eric?
Yeah, I can jump in for,
go ahead.
I'm sorry, for New York City Helping Hospitals. I think similarly, like we have internal dollars within H&H, which we've used to kind of seed funding for some of these kinds of things. But in addition to that, as a safety net hospital, we also are drawing down funds from city government to support things like our community health worker program. And there are sort of smaller buckets of funding as well that are often available to us to be able to kind of try these newer, more integrated models as well. So that's sort of a unique position, perhaps, of H&H.
Erica, I think you were going to say something.
Oh yeah, no, and I am not an expert, so I'm with an upstate IPA that's focused on social care organizations, but integrating all of the care providers. But I think too, if health systems could engage in like looking at things that really affect their operational costs, like, you know, bed days and things like that in terms of solutions. So like how would the CBOs save, you know, organizations help save on extended bed stays that really cost the health system a lot of money. And then therefore, how do we share in some of those savings across the network? So, you know, I think of an example of like a medical respite or something like that that can help transition somebody who needs a little bit more than a homeless shelter quickly out of the hospital and get discharged, which ultimately helps the health system's bottom line too.
Anyone else? All right. The last question here, I guess it's question is, what is your sector specific and unique funding interest? And I think related to expanding access to community resources. Any thoughts on that? I think that's probably more related to philanthropy and government organizations. That's what it states here. Jack, is that right? Is that?
No, yeah, I think it's fine to ask this group if they had money, where would they be investing it when it comes to this work, because it might help generate some thinking around what has been used within healthcare and hospital systems to fund this. I know, you know, building this work into training programs would be something that only hospitals and health systems could do, and resources only hospitals and health systems could tap into via, you know, their work in training the healthcare workforce. But are there other kind of resources that are exclusive to healthcare institutions that can be leveraged to support the work?
I think it's important to remember that not all hospitals and health systems are sort of on equal footing when it comes to their financials. And so I think, you know, we all know the sector very well. So we know that there are hospitals that do have resources and that do make investments. And then there are others where it's really just frankly hard to keep them up with kind of what's going on with this space or in this space. And that are concerned about kind of making payroll at the end of the week, and who have, you know, trouble thinking about, not thinking about, who may not get value out of value-based payment arrangements because they, you know, there may not be a lot of savings to be had, and that could be for a lot of reasons, right? It could be there are operational improvements that might need to be made that could help to achieve some savings. But anyway, I think it's, you know, just as we talk about how, you know, one CBO is one CBO, I think it's similar to the hospitals. They sometimes get lumped into this thing, and they can all be a little bit different. And so I think that's just something to note. And I think part of this work is engaging the safety net hospitals that may not have the funds to invest, at least at this time, but they are also very, very important to this work and serve the same communities.
Well, and they can procure. I mean, this can be a fundraising part of a health system or community health centers fundraising strategy, right? If they're funding things, like you mentioned, Carla, funded projects to improve screening and data collection internally on health-related social needs, or building their community health worker workforce that's going to connect people to the community resources. So I'm not just talking about what can healthcare cough up. I'm talking about what can healthcare raise in this endeavor for themselves and, you know, their partners.
I would just add to that too, looking at it as a program, you know, like if you're trying to solve a community problem and maybe that health center would be lead, but participate with the CBOs or other supporting organizations.
I think that the value of community health workers has been tremendous as far as, what we've been able to accomplish. And, I think we have to be more, think strategically on how it benefits, us as well, as far as discharges, decreasing length of stay, because you're able to connect patients to community resources more quickly because you have those connections. Things like that. If you can be, thinking creatively like that, I think it's a way to kind of think about how we can invest in the community and help also struggling institutions maybe that so and the other thing we've thought about is how do we use our human capital to join some of these local community organizations and help them think outside the box themselves, so inviting some of our staff to go out and join community CBO boards and help them think about how to raise money through grants and help them develop that infrastructure. So I think, Zach, we'll go to the next question. Is that okay?
Yep.
So the next question is create an administrative backbone and infrastructure to support and facilitate the work of community-based organizations at all levels of capacity. We have discussed that many obstacles and barriers into collaboration across sectors and agreed that the capacity development support for CBOs is critical to health equity approach. Further, in New York City, many small culturally specific organizations are essential to reaching into and serving the diverse communities and populations of New York City. Previous sessions identified the need to both internal organization capacity development as well as capacities and capabilities needed to manage an effective network. First question is, what do you view as your sector's role in, if any, in building the CBO capacity, and what do you do if you could, and what would you prefer to be handled by a network administrator? So there's two questions there. So the first one is, what do you view as your sector, if any, in building CBO capacity? Any thoughts on that? Is it important for hospitals to build CBO capacities? So I'll share my thoughts and then open it up to everyone. But I don't want to, manipulate everything. If you can please just, join me in thinking through these things so we can come up with some really cross sectors. Because Carla, as you said, not all hospitals are the same, right? So there's, one of the things that we've been focused on is creating capacity in developing community infrastructure. And, I think it's important, specifically for the question that was asked originally, that to look at, the people that are the communities that have large undocumented and disconnected communities from care. It's extremely valuable to work collaboratively with community-based organizations, and I think here it's specifically organizations that that target those specific communities, because those patients are going to show up in your emergency rooms anyway, and the care that you're going to provide in the emergency room is much more expensive. And my opinion is that you try to work with CBOs that target those populations and do a lot of work with them to develop relationships and build some programs to get them connected to services, and then instead of waiting for them to come to the emergency room to get their care. So I'd love to hear your thoughts on on that.
I think part of it is asking the CBOs where they think they would need assistance.
Mhm.
And then, that might be a good way to come up with where there can be some focus or support. And then it's kind of less focused on what the hospitals
Oh, yeah.
want, but more, not that I'm suggesting you didn't do that.
No, you're absolutely right. I'm glad you
But I think
clarified that.
starting with the ask.
Yeah, you got to listen first and then hear what their needs are, and that's how you develop trust, and that's important for sure. Emily,
Yeah, I feel like I can chime in on that. I'm
Yeah.
Emily Foote from Health and Hospitals. I oversee our medical legal partnership with NYLAG. So a lot of the
Yeah.
patients that we're serving through that are in fact immigrants, some of whom are undocumented, lots of legal issues. And I totally agree about this really so much opportunity for working with CBOs around supporting the immigrant population. Interestingly, I think there's also room for bigger and better relationships. I mean, we do have pretty strong relationships with a lot of the lead immigration-focused CBOs and networks. But I was involved recently with a study that the Center for Migration Studies did, looking at sort of the impact in particular of recent immigration policies on the community and sort of the culture of fear and the decline in accessing services, healthcare services, and also other benefits. And I think from the preliminary results, it seems as though many immigrant New Yorkers actually are, in some cases, more likely to apply for benefits in a healthcare setting. And I think, though, that healthcare still obviously has a ways to go in terms of really understanding like how to communicate in a way that builds trust. We've done a lot, and I think we could do more, and we could really look to the CBOs for their expertise here in sort of language, in particular, being a big thing, language accessibility and messaging, and then message channels. So I totally agree that this is an area for continued collaboration and growth.
It's sometimes talked about that health systems or hospitals want to be able to refer their patients to community resources, but that landscape is difficult to understand, and they're not very confident. They're not always very sure that people are going to get what it is that they need or solve the problem that they need to solve. So are there certain capacities that healthcare would want to see developed, among community-based organizations that would help solve that challenge? Sometimes it's co-location, sometimes it's shared workforce. There's lots of different strategies that have been tried, but what would make it easier for collaboration between health systems and CBOs? What capacities would make it easier?
I think that one of the ways is as I think we've all I think experienced with and I saw that Unite Us is one of the people that are part of the conversation, but having we've used NowPow, and now Unite Us taking over NowPow, and I think that having that close loop referrals would be a good way to kind of because I think that sometimes we over refer because we don't know, like you were saying, that whether those that client or that patient was taken care of or received the services that they needed. And so sometimes you're I find that our providers are looking for multiple ways of helping this patient and will over refer, and so So creating a one, I think one mechanism to be able to do that, and I think the CBOs, as I speak to them, struggle with the diversity of IT, infrastructures, and not just, all the other ones that are available now. And some of the CBOs have to have 3 or 4 different, softwares to be able to communicate with all our hospitals and with whoever else refers to them, and even referral within their own, or within the CBOs themselves. So I think having something like that would be beneficial.
Yeah, I would definitely agree with that. I think that's certainly been our experience as well, working with CBOs, is just their ability to navigate all the various tools is a challenge, even if they want to be able to kind of close that loop. So building capacity around that and having some sort of standard to increase transparency would be a huge value add. And I think we've seen that be really successful with some of our partners. And I think that kind of goes back to the first part of your question as well, around like, what is our role with capacity building? One of the things that I think potentially benefits both healthcare and CBOs is having sort of shared standards around what, like, definitions of referrals, enrollments, and like what that data collection and sharing process looks like. And, with, again, like with some of our partners, I think we have a clear way to do that. And with others, I think it's murkier because we don't necessarily have the tools. So that definitely feels like a good direction to want to be moving in if possible.
This is Yiting Chung from Mount Sinai. I'll just add to that from an IT perspective. I think in addition to just sheer number of tools that are out there for making referrals, we also need to consider that different CBOs, depending on the referral, may require different level of data sharing. So some may require a whole lot more than others. So how does consent fit into that, and so that we, on one hand, have the infrastructure to support that data sharing, but on the other hand, also respect patients' privacy, knowing that even though it is related, social referrals are related to that clinical outcome. And as an IT person, the more data, the better. But at the same time, how do we also respect that there is a difference?
Would you say that's also a compliance, like a capacity on the CBO side around health information, protected health information, and compliance is an important capacity for CBOs to have if they want to partner with healthcare?
Absolutely. I think we haven't really gotten that far to even have that expectation of the CBOs. But just working with our own healthcare compliance, our own health system compliance, and knowing all of their concerns, I think once we get to a point where that faucet really gets open and we can share a whole lot more data, I would think that at some point we would set some level of compliance expectation from CBOs, and knowing how stretched they are, that could be a challenge.
And that becomes even more relevant if there's Medicaid billing involved. And I think that's part of the future, is that right, there might be some funded partnerships or funded programs with hospitals and health systems, but if the payers are going to reimburse, then that's an extremely, it's necessary, or billing's not possible. and I think that, because I think we kind of stopped answering the question, but I think that the hospitals and health systems could potentially help with that education if it's a need. We are well versed in privacy and compliance issues.
Sure. Okay, so yeah, I think we can move to the next question, Zach, is that right? So the third question is systematically build local community engagement and participation into planning, design, and implementation and evaluation. Previous sessions reveal the importance of engaging the intended beneficiaries of systems reform in planning, design, and implementation and evaluation of those reforms, and that this engagement was essential to advancing health equity. What is your sector's current approach to engaging communities in that work?
I'm struggling with this one a little bit, actually. And so maybe, I don't know if there's more context, or maybe maybe I'm just looking at it the wrong way, but I think I guess I would say I'm not sure what the healthcare role should be in this, other than like participating or kind of doing what's asked. Because I think that, you know, and I think others should definitely weigh in, but I don't know if this is the kind of, we spent many years talking about the big health systems and the big hospitals, right, taking over discussions and taking over planning, and that's obviously not the goal or the intention here. And so I guess my answer would be that the role of the hospitals and health systems would be to participate. But
I think what we're looking for here is what is in place that we can lift up from healthcare. And I think healthcare is strong in this regard in terms of its ability to engage with local communities and with patients. I mean, if you think about everything that goes into developing a community health needs assessment, if you think about all of the activities that outpatient clinics engage in with their patient populations to evaluate how their clinic is doing, and what services they would like or need. So what we're talking about is like, what is your current approach to engaging communities? And you think of it as patients in your work, and how can we take advantage of those ways you have of communicating with patients to ask them about their health-related social needs and priorities, and their desire, willingness to participate in a community resource network or access these kind of resources.
okay,
Is that helpful?
That's yes, very helpful. Thank you. I did that wrong. So then, you know, I would say to that point, screening and referral would be important. Educating patients or providing information on the existence of a community resource network, and you know, this would be a new entity to patients, and perhaps, you know, kind of thinking through what's the best way to frame this so that patients avail themselves of the services. So yeah, I think in that regard, there's a lot that the providers can help do.
So can I comment on Jill? So we do screen our patients for social determinants of health, and we then refer them to services in the community for some of those. But you know, like you said, I mean, we do our community health needs assessment. That's definitely a way for us to engage community input and understand what the community needs are, and use that document as a driver to create programs that benefit the communities that we're serving. Um, you know, and So for me, and when we're actually creating our community service plan, co-designing some of the programs with community-based organizations, so that they have a stake in the in what we're trying to do to address some of the needs of the community.
Just, I'm not sure if we're raising our,
Yeah.
just real quick. I think two things that maybe tying into what Carla, I think was talking about with the referrals and so forth. It makes such a huge difference when that health system person really like explains what's going to happen to the individual when they get referred. So that like that connectedness, somehow building that in so that there's a consistent engagement across the way, so they know what's coming instead of like getting some random phone call. And then this is just a comment about like planning groups and community-based organizations in general. I think, what we've found is sometimes if you're not focused enough on the patient or the member or the human and their feedback, and you're looking to, community organizations or really broad assessments, you're not going to get the boots on the, like the people what their actual experience has been. And I think sometimes that can be really different than what all of those who are acting in the care and think. So I think that's really important, and maybe even building in less doing like these big planning things that like take a long time and a lot of people's input and all this stuff, and more the feedback loop of doing, hearing and pulling that together and saying, and adjusting. So more, maybe more iterative than these big things. That's it.
Yeah, I think that's a good point, like leveraging experience and like continuous quality improvement. Yeah, I think that's right. I would also add, and this might be kind of cross-cutting across all of the actions, but educating internally providers and staff and the hospital workforce, because we have challenges referring patients from primary care to specialties, and the specialty could be next door or down the hall, and we don't always do that right. And so I think now you're talking about a whole different sector. So this has come up before. This came up in this conversation already. Helping to ensure that referrals are correct and things like that. But I think, it's really important to educate the healthcare workforce on what this is. And, we have fancy EHRs that can probably help with some decision support, so that referrals are correct and it doesn't put the burden on the CBOs to figure out like where this housing referral really is supposed to go. And so just thinking through that kind of education, and then taking that action instead of relying on the other sectors.
Great.
I think we are ready to move to 4, or we're
Great.
coming close to the time. So
Yeah.
at 9:45, I'm going to give a summary of what are the takeaways so far.
Okay, great. So the fourth one is employ regulatory methods and advance policy and practice that ensures favorable technology ecosystems. Previous sessions identified the need for consensus and standardization around effective data sharing. So that's one of the things we kind of were talking about before. And so what can your sector specifically do to minimize the potential access barriers created by the proprietary nature of technology ecosystems? That's a big one. And not easy resolvable, but happy to, because I haven't figured that one out yet. So I'd love to hear from everyone. Carla, you have the perspective of several hospitals, right? Because you Greater New York. Have you heard of anything that?
Well, I think that there's work in this area going on at the national level. And so I think there's this like, you know, should we do it? Should we work on this and then change it when we get these like federal rules or these, you know, EHR standards, you know, or information exchange standards, or do we wait? And I don't know the I don't know the answer to that either. But you know, for those that have been following the Siren, what's it called? What's that project?
Gravity Project.
Gravity.
Thank you.
Yeah.
I mean, that was supposed to be like 1 year and cover 4 domains, and it's been 2.5 years, and they've done a lot of work. I mean, don't get me wrong, but like, where are those standards that we were supposed to have? Because, you know, so sorry, I'm ruining the conversation.
No, I was just as bad when I started this. Anyone have any thoughts? Anything from Health and Hospitals that can help us, maybe? No?
I think,
I
you know,
can.
oh, go ahead.
Oh, go ahead, Carla. No.
No, I talk a lot, you go.
I mean, I really can't answer the big question. It's the right question. Little pieces of it that I think are, I mean, I just have to echo what Carla said about sort of that risk benefit analysis. I think that people at a very senior level are doing about investing now versus like waiting until the landscape is clearer and then making choices. There's benefits to both and risks to both, and it's hard. And I think for H&H, perhaps similarly for NYP, like we invested in NowPow and we have spent so much time, you know, even prior to integration with Epic, our EHR, you know, lots of time trying to sort of sell the platform to primarily our social work workforce before we had such a big workforce of community health workers, and then all the time to the technical work to integrate into the EHR, more training. We've made vast improvements. We're not where we want to be in terms of closing the loop or making progress, and then suddenly like huge change coming down the pike.
Yeah.
Big opportunities absolutely come with it, with sort of maybe push from private sector on healthcare and or regulatory bodies to streamline some of this stuff. But for the healthcare system, it's like, okay, now what do we do? And then the other thing I'll just say very briefly, I think that feels like it's not an easier lift, I don't think, but simpler perhaps, is around HIPAA law and treatment of social services as part of healthcare, and whether there's collective advocacy we can do to just boil it down a little bit and make a simpler case. It feels like right now, like the case is too complex, and so it doesn't resonate maybe as much for the legal regulatory body. So I'll stop talking as well.
That was well said. We're having the same problems at NYP. So I heard in South Carolina there was didn't they decide that they would go with one platform for the whole state or something like that?
North Carolina.
North Carolina.
North Carolina, right?
Mhm.
That seems to be the way to go. But
My 2 cents is to look at like the landscape of technology will constantly change, and there'll always be lots of things and tools and stuff, and to look at them that way. And I guess that's where I see the advocacy around the interoperability is really, 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 really important, because it's not going to be, Epic versus, I don't know. Epic's not going to be everywhere, or maybe they will for a moment. Like, it's just going to constantly change. So if there's more regulatory focus on having these things be interoperable, then it's less of the end users getting thrown around. But that's my.
And I think we
2
have
cents.
more control on the operational side, and we could, I don't know, all use the same screening tool. Like, how about that? and we could all get really good at training providers to code, right? And there are things that we could do internally to standardize things that might facilitate this activity until the interoperability piece catches up. So that might be like an early thing that we could do.
This was actually a lot of really helpful comments and feedback. And I'm going to try to summarize the key takeaways, and people can tell me if I got it right or not. So under key action 1, what do you see as your sector's role in financing a community resource network, and what sources of funding would support startup and ongoing costs that your sector is uniquely qualified to tap into? I think the key takeaways here were that healthcare systems can invest in improving screening and data collection internally on health-related social needs. Community benefit dollars are one source of funding health systems can tap into. There may be resources available that can support the community health worker workforce specifically. So funding and building that workforce is one thing that healthcare can tap into, one investment that healthcare can tap into. Some health systems use internal dollars to seed and try out new models, or to tap into local government resources if they're safety net hospitals. There are also ways of solidifying shared investment by placing healthcare leadership on community-based organization boards. And then later on was mentioned that educating, there may be resources that can be raised that support educating the healthcare workforce about health-related social needs. Does that sound like everything we covered for a question for the first action step?
Yeah.
For the second one, which is really about administrative backbone infrastructure to facilitate the work of CBOs, I think the key takeaways here were that health systems would be interested in CBOs that work with populations who are high acute care users, emergency department and other acute care users, that CBO language accessibility and communication tools for communicating between CBOs and health systems was an important capacity. Technology capabilities, shared standards around definitions of referrals and what's meant by a referral and enrollment, agreement on how data is shared and managed. So sort of a lot of capacity development for CBOs around data and defining data according to the same terms. And then consent and compliance, as well as billing systems and billing methodologies would be useful capacities for CBOs to develop, and healthcare could support some of those CBOs.
Zach?
Yeah.
Thanks so much for the summary. I just want to clarify one thing about the language access and CBO sort of expertise. And what I meant to say, perhaps didn't say well, was that I think they have expertise in really communicating with patients and clients in those communities that I think healthcare could learn more from. So sort of methods of communication as well as the various language needs, and sort of finding out from patients what they need from healthcare when they come into a healthcare setting.
Yeah, so the language accessibility that CBOs have is a value, is what I'm hearing you saying. It's a value for healthcare. Yeah, great. Under the third, building community engagement and participation, community health needs assessment process can be used to engage with communities on their health-related social needs. Co-designing community service plans with community-based organizations, leveraging the patient-provider relationship, the trusted patient-provider relationship to talk about other needs, health-related social needs, direct feedback loop with patients and participants, applying CQI methodologies that are well developed in healthcare, are ways in which healthcare might engage patients systematically in participating in a community resource network. And on technology, try to take advantage of what's happening at the national level, but do some risk benefit analysis to assess what needs to be done now versus what can await better standards. Thoughtfully consider and prioritize integrations. Collectively advocate on HIPAA law and other interoperability policy that facilitates the collaboration, as well as come to agreement on screening tools and getting providers to code properly in order to lay the groundwork for the future. Got it? Wow, we're right on time.
I'm going to ruin that. I'm sorry.
No, well, we don't have a pop-up yet, so I don't know. We can't go anywhere.
I'll be quick on this. I just want to clarify something on community benefit that I think is important. So community benefit is it's an accounting function. So the hospitals don't, all the hospitals might kind of work their community benefit like dollars differently, but it's not in all cases like a bucket of money, like a grant, or it's not always allocated dollars. So and I think there's this assumption that, right, the hospitals have this budget for community benefit, and that's not always how it works. Some might do that, some might not. So I think maybe just making the language clear that they might strategically use their community benefit requirement to support programs or CRN programs that like align, that are strategically or aligned with, between the CBOs and the hospitals. But sometimes it gets talked about like it's this bucket of money, and that's not what it is.
No, I think you're absolutely right. It's, you have to demonstrate which of your dollars you're deploying for the community benefit.
Exactly. So it's like, how are you going to use the money that you're.
But you can think through like which areas of your work are truly embedded in the community and who are you partnering with there.
Absolutely.
Having written a health needs assessment and run a CSP, I know.
Yeah, you know this very well.
What's involved.
Yeah.
But yeah, I think it's not new money. It's
right, and I think the language around it can be confusing to those who who aren't familiar with the process. So we don't need to talk about accounting, but I think we should just
strategically deploy community benefit requirement dollars or resources.
I think that
even, yeah.
Yeah.
Thank you, Carla, for saying that. Clarifying.